just a brief outline of what I want to talk about this morning. I want to talk a little bit about why we're even talking about cancer survivorship and psychosocial outcomes briefly. And then I want to focus on some of the behavioral health needs of survivors. We want to talk about off-treatment transition, which is can be challenging for many people. I want to talk about mind-body issues that come up after treatment's over. Talk about emotional health issues, and then talk a little bit about acceptance and finding meaning at the end. I'm going to focus on really the later phases of cancer treatment, sort of the early off-treatment transition, so right when treatment ends, sort of early off-treatment, just as people are adjusting and getting back on their feet, and then the longer-term off-treatment period that can take years or decades in some cases. I'm going to be trying to cover a lot of ground, as you can see, and so I'm going to be generalizing in order to do that, right? Lots of different cancers, lots of different treatments, lots of different medical effects, different types of people, age, income, rural, etc. I'm going to try to pick some examples that I think will illustrate the kinds of issues that come up for people generally, but individual people or programs are going to have to translate what I'm talking about for the particular population that you may be thinking about or working with. I am talking about off-treatment folks, but I also need to acknowledge some of those people are assuming that they're off treatment for good, and some people are assuming they're off treatment for now and maybe on treatment or likely to be on treatment again later, so that's another difference. So to start out, why are we talking about survivors? I don't get this question anymore. I used to a long time ago. I would say, I work with DNFR with cancer survivors. I'd say, you don't survive, like, it's over, like, good, it's over. Like, what do you do? I don't get that anymore overtly, but I do get the look where people are like, oh, cancer survivors, and you see them thinking. So there's a few important reasons. I don't have to tell this audience. One of the reasons is there's so many, right? We have so many more survivors now, and will have more survivors. 20 million, 24 million by 2040. It's a growing population. Why do we have so many? There's epidemiologists and data science people in the room. I won't spend too much time talking about this, but we have so many because we have an aging population. We have much more effective treatments. We have early detection. Those things are all great. It's really building the population. And there's another side to that, which is a lot of those intensive treatments have late effects, have challenges during the course of treatment that we also have to address. And that's a lot of my patients will say to me, it's not over when it's over. There are off-treatment transition challenge, which I mentioned, and there are long-term late effects for people. There are many different kinds. They touch on different aspects of people's lives. And so all of those things need to be taken into how we think about and how we respond to the challenges that people face after treatment. I will say, I'm taking a little bit of a different tact here today for me. So you will hear me say I've already sort of said things that may sound contradictory, right? Like people are living longer, so that's good. People are older, but it means you get more cancers. We have more treatments, and that's really good, but also treatments have late effects. It may sound like these things are disjointed or they don't go together. And I think part of the problem is that we simplify things they're complicated things, we simplify them to try to break them down into pieces we can understand. But sometimes we end up with pieces and we lose the whole picture. And I think sometimes when we say but, it is kind of reinforcing the idea that these things don't go together. We do that sometimes in a population level when we talk about survivorship as a whole. We also do it when we talk about individuals. And so I'm trying, in my own practice, I am trying to think a little bit more about saying and rather than but. And I don't usually go in for changing language a lot. People say they don't call them students, they call them learners, they call patients. I'm almost thinking, really? Does that help the kids a lot to call them learners? I don't know. But so this is an experiment for me, but I'll ask you to join me as we talk about these things today and think about how we can integrate these things. We don't want to be like the blind man and the elephant. We're all calling out the different pieces and saying, but this doesn't make sense. They don't go together. Well, the elephant understands how they go together. We need to get the big picture as we talk about these things. Part of the big picture, I want to use this illustration, which is this is how many people think about distress and sort of psychological impairment in the general population. Most of us are in sort of the blue phase. We have good days and bad days and challenges, but for the most part, most of the time we have pretty low distress and pretty low impairment. We're able to do what we need to do. There's a group in the middle, has sort of mild or moderate distress and impairment, some challenges, things we're not achieving, we're not able to do, we're having more distress than average. And then there's a small group at the top that has extreme distress, significant impairment. And those are the folks we usually think of in my world as having a psychiatric diagnosis or needing, significant clinical care. So if this is the typical population, we think that in cancer survivors, the population looks different. So there's not as many people down in the blue who are just, I'm great. That population gets a little smaller in survivors, we think. The middle population, people like, I'm doing okay, but I'm struggling. Like, you might not know it if you see me in the grocery store, but I'm actually not doing so great. That population gets pretty big. And then at the top, the people who are significantly impaired, that population probably doesn't get all that much bigger. Maybe a little bit, but it's not really, to my mind, and what the data suggests, where the action is. So I'm saying a little yes and here. Yes, psychosocial problems are common after cancer, and most people are not distressed, and if they are, they're mildly or moderately distressed. So it's important, I think, as we launch into this, to kind of have that as a background or a lens. So to jump into some of the areas I wanted to talk about, I do want to talk about managing transitions, and particularly the early off-treatment transition, that may be sort of a stand-in for other transitions that people may be going through. When we talk about mind-body health, the example I'm going to use is fatigue. There are others that we could talk about, but again, I'm trying to use an approach I think could be applied to things like insomnia, sexual health, pain, cognitive difficulties, etc. And then I'll talk at the end about more emotional issues in a purer sense, and I'm going to use anxiety as the example. So in this work that I'm talking about today, it really kind of mirrors my approach talking with patients and families, which is sort of anticipatory guidance. So I'm going to talk about a bunch of different problems. I don't think anyone has all of these problems, certainly hope not. I'm going to try to talk about things that can happen, that people might want to know about, and anticipate what they might want to do if those problems arise. So as I said, this early off-treatment transition is pretty challenging. Now, one of the reasons it's challenging is because it comes as a surprise for a lot of people. People will say, I've been waiting for my treatment to be over, so why is it so hard for me when it's ending? People will say, after a year of diagnosis, treatment is finally over. I say my psyche heaved a sigh of relief and gave itself permission to implode. And people will often say, what's wrong with me? I should be happy. Everyone says, oh, you must be so happy, and I feel terrible. Again, I don't think it really should be that surprising if we step back and we think of an and model rather than I'm happy, but I'm terrified or feeling sad. We know changes are hard. We know positive changes are challenging, right? You get a new job, you get married, you have a new kid, you're really excited, and it's really challenging to manage those new things. So I think in some ways we need to recognize, of course, the transition is going to be hard and not make ourselves or make other people feel surprised and say, right, so what's going to help? What sort of information, what sort of support can be useful? I think managing medical care is a challenge for a lot of people. People typically during treatment have a lot of connections with nurses at home, on the phone, in the clinic, and suddenly that goes away and people start feeling like they don't know exactly what's going on. What do I do if I have this symptom? When do I come back? Why am I having this test? Why am I not having this test? It's kind of been built in during treatment, hopefully, to get some answers to those questions, and that starts to go away for people. I think it's important for survivors at this phase to understand that their medical providers can give them some information. But typically, most survivors' experience is that survivors have to ask. And they have to ask more than once. And they have to ask over time because the answers change over time. And so it kind of falls what may have been on the medical team who was very active at telling you all these things. Next week you have this, next month you have that. Suddenly it's radio silence. And you have to say, I'm sorry, when do I have that? Or that thing I did last month, am I still doing that this month? Because the information that sometimes it's too much information all at once during treatment, and suddenly the tap turns off. And so people really need to know that that becomes part of how they need to manage this transition. For some people, having a plan, a written plan that you talk about with your team can be really helpful to tell you what's happening when, what tests are happening. If that fits your needs, that's perfect. It's important to understand, though, it doesn't work for everyone. Some people don't want to know all that information, or they don't want to know it at certain times. So for some people, this kind of stuff can actually promote more distress. I have a lot of patients in the clinic I work with who say, would everyone just stop telling me what's, just tell me the date I need to come back to the clinic and I will come back. I don't need to know everything that's going to happen. I just tell me what I need to do and I'll do it. That's fine too. And it sort of illustrates how people need to figure out what kind of way of managing information is going to be useful for them. There's oftentimes people, again, not anticipate a loss of supports. People say, I was in treatment, this closed, I went to radiation treatment every day, the staff became like part of my family. And then when I finished, there was this instant separation and I felt a real loss. A lot of times people need to work on that by recognizing it and thinking about they may need more supports. They may have not really needed a support group during treatment. They were too busy, they weren't feeling well, and they may think, that's funny, now treatment's over, I actually need some of this that I didn't need before. But this transition may be a time that those things become more important. It's also, friends and family are often there to try to support you and celebrate when treatment is over. They may not understand how complex it is for you. And so part of the work, again, that falls on the survivor typically is to let them know that there may be some challenges and to let them know how they can be helpful. I'll talk a bit more about that. Sometimes in the off-treatment transition, there's readjustment to roles. Treatment can be really absorbing for people. And so maybe things have shifted in your home. Maybe you used to pay the bills during your treatment, but someone else has been paying the bills for the last few months. And now do I go back to paying the bills, or are you paying the bills? Did someone remember to pay the water bill? Maybe, things need to be kind of looked at again. There may be extended family things. You've been checking on your mom and suddenly someone else needs to check on your mom. And how do you go back to what you were doing before, or is what's working now working okay? Some things, survivors talk about decisions being put on hold. They were maybe thinking of moving and then they had a diagnosis, or they were thinking of changing their jobs. And so those questions sometimes need to be readdressed to think about, am I still thinking about that change, or am I not still thinking about that change? And often that involves other folks, family especially. People, often survivors will tell me, people see me in different ways. It's so interesting. Like my kids think I'm really fragile and that I shouldn't do anything. And then my neighbor thinks I should go out and play 18 holes of golf like 2 days after my last infusion. It's like, what is wrong with people? And I often say to them, well, they don't know, right? They don't know if you don't tell them that this is what you need, or this is what you need now, and it may change. It also may be hard. Sometimes survivors themselves don't really know. It's like life feels on different days. Sometimes I think I could play 18 holes of golf, and other times I don't. And so part of that is the transition that's both for the individual to figure out and come to terms with, but also to let other people know what's going on. These are some of the things that people, survivors that I've worked with have told me have been successful for them, is to be able to say, yeah, I'm feeling better and I still need help with this. Or, to the kids who are, overly attentive to their dad, to be able to say, thank you for this. I actually feel okay to do the laundry, but I really need help with something else. If you can have those conversations, which don't come naturally for a lot of us, it can really kind of smooth these transitions. So I guess to summarize, many survivors, it's very positive. Everyone wants treatment to be over. And many survivors also have some challenges. It often takes time to sort them out, and if you get past the surprise, you can find that time. It's important to understand people react differently and need different things. It is important to expect that things smooth out over the first few months. That's pretty typical for people, that their adjustment, a few months later, they're feeling better, and some of these things get sorted out. So going into it with an optimistic view makes sense. It is important to know that some survivors do report a sort of delayed emotional reaction. I hear often patients like, oh yeah, I got through treatment, I was a good soldier, was totally fine, got out, and completely just cried for days. And that freaks them out oftentimes. But be able to talk about them, well, that's kind of probably those tears are from before, and you coped with them in a way that's really good for you to get through the treatment and kind of do what you needed to do. And like a lot of things, the after effect is now, needing to process that, and it generally gets better with time. It's also important to know that if things are difficult, more challenging than is easy to manage or last a longer time, it is important to seek some kind of medical or emotional support for things that aren't resolving. And that's sort of what we're going to talk about now. So I want to talk about mind-body issues. And I picked fatigue, although I said it's sort of a stand-in for a whole bunch of other mind-body issues. And I want to talk about sort of an approach to dealing with these issues, which includes a few different steps that you can see there. And I want to go through them specifically for fatigue. And again, these are more issues in the later stages of survivorship. So cancer-related fatigue is sort of consistent, persistent fatigue that's not proportional to recent activity. It doesn't respond to rest, and it interferes with usual functioning. It affects a lot of people during treatment. Probably 80% of patients say that they have serious fatigue during treatment, but about 20 to 30% of survivors 1 year later. That's a lot of people. Now, it's not most people, which is great. So 80% don't have it, which is great, but that's a fair amount of people. And one of the reasons I wanted to pick this. So when I work with survivors with fatigue, which I've done individually and in groups, they're often really surprised about it. It's so persistent. It doesn't get better. It's their whole body. It doesn't matter how much they exert themselves. It doesn't matter how much they rest. The fatigue just really feels total. The first step for all of these mind-body things is to have a really good body evaluation. There are many, many organ systems, there are many, many functions of our bodies that can affect these things, particularly fatigue. I'm not going to go through these, but all of these things need to be evaluated by your medical team, could be your oncologist, could be your primary care doctor, could be both, to make sure they're not contributing. If there's something treatable that's increasing or causing the fatigue, it's important to get that addressed. A big part of fatigue, of course, is physical deconditioning. Fatigued people rest to conserve their energy. So on treatment, a lot of people are napping, they're spending time on the couch, they're not exercising or active the way that they were. It's an important short-term solution. You don't have energy, so you don't use energy. The problem is when you have excess rest, you lose your fitness. So you have less aerobic capacity, walking up the steps is harder, you have less muscle mass, you have less muscle energy. And so over time, you lose your fitness. And without fitness, ordinary activities become very, very difficult. They make you fatigued, and so you rest. And so it becomes this vicious cycle that's very hard to get out of. But it really is a use it or lose it kind of situation. So we really talk with survivors both mentally and also physically about taking a rehabilitation approach. And I say to people in fatigue groups, yeah, I know you've had cancer and this happened and you spent all this time on the couch and now you're resting. But if I told you I was having like hip replacement next week And my plan was to stay on the couch for 6 weeks until I healed and then get up and try to walk. And they all laugh, right? Because we all have friends who've had hip replacements, and we know that is not how that works, right? You have a hip replacement, they have you up like that day. If they could get you walking out of the operating room, they would try that. Not because they know that's the important thing to getting back. And so we really talk about people, try to get them into this idea of physical activity in a rehab zone. So a little bit more activity and rest, but not so much that it's harmful. And that can be very difficult, as we'll talk about. Sometimes we point out to people, particularly gentlemen, who think that they can jump off the couch and go back to running or tennis or whatever, that if we have star athletes who are injured and are out for 9 or 10 months after a single surgery, it probably doesn't make sense that those of us in our 60s and 70s could do what they can't do, right? Put that in perspective. So rehabilitation here is exercise, and this is the thing, like when you say that to a group of fatigued people, exercise, you know the moaning and groaning. But that's part of it, just like the hip replacement patient. It doesn't feel good all the time, but it's how we have to get started. We talk about walking, we talk about other activities, we talk about having realistic expectations. And for people who really haven't been active in a while, or particularly weren't active before their treatment, we talk about getting professional advice. It's really important to do it and not overdo it, and that's really hard for a lot of people. But the activity really needs to be in a rehabilitation zone. It's enough to get you moving and not enough that you're harming yourself. There's a lot of evidence that these mind-body interventions, Tai Chi, mindfulness, meditation can be helpful for people who are trying to manage fatigue. So it's something that we encourage. There's also a lot of evidence that cognitive behavioral therapy is helpful for fatigue, and I'll talk a little bit about this. Basically, the idea is people who have fatigue have a lot of thoughts and a lot of feelings about their fatigue that often get in the trouble of them being more active. So we'll talk about that in a moment. So to try to address the lack of activity and specifically their health worries can be really important for these folks. So I'll give you an example. This is a gentleman, it's not his real name, but the Jackrabbit part was his nickname in the group because he was very active before his treatment. He came to the group, he told us he had gone out, he was going to walk several miles first day, and he couldn't do it, and he came home, and he was exhausted, he was embarrassed, he was defeated, it was terrible, and then he was like on the couch and didn't leave the house for several days. And this happens a lot with our survivors. People try to go back to what they used to do, wish they could do, their friend does, and they overdo it, and then they stop. Because it didn't feel good emotionally or physically. So we need to address that in a lot of ways with folks. This is another woman who was also in our group. She's sort of the other side of the situation. She had been very isolated after treatment, and the problem she brought to group one day was friends invited her out to go dinner and shopping, but she couldn't go because what if she couldn't do it? What if it was too much? She would be embarrassed. She'd hold her friends back. She just felt really torn. And so she stayed home and she felt really sad and frustrated and didn't know what to do. So this was a clear case where we knew we needed to deal with some of those thoughts to help her be able to be more active. And I'll talk about that a little bit later. So I want to transition to emotional health. And again, here I'm picking on anxiety because it is very common and it's also very treatable. So it's very common in the general population. So about 30% of us will have an anxiety disorder at some point in our life. It may last a few weeks, a few months, a few years, but it's very common. And any particular day, probably about 4, maybe 5% of the population have significant anxiety. And it is 10%, we think, in cancer survivors. So again, I point out, people like me, because I'm trying to write a grant, try to prepare a paper, and we say, it's, more than 3 times as much or twice as much, anxiety in cancer survivors as not. And we don't say, but 90% of them don't have it. right? So I think I point that out because it is a sort of thought glitch that happens to us in our field, whether it's fundraising or epidemiology. But I think we do a disservice to cancer survivors if they hear just that headline. It's twice as common or more than twice as common. We need to give a more full picture to help people see where they fit in. So about 30% of survivors overall are bothered by symptoms of anxiety, even if it's not severe. And there are different flavors of anxiety. I'm not going to go into all of this, but people have maybe heard of generalized anxiety, which is a lot of worry, panic disorder, which involves specific panic attacks and then fear of later attacks, social anxiety, and fear of cancer recurrence is something we hear about more. I will say I'm not really sure what to make of fear of cancer recurrence for two reasons. One is, as a researcher, when I read the research, it's a little hard for me to make sense out of because people define fear of cancer recurrence really differently. And so it's hard for me to get the big elephant picture. Also, when the research is done, sometimes the population have a significant chance of research. Their doctors are telling them of recurrence. There's a significant chance of recurrence. And other times, because of the disease or treatment people have, they're being told by their doctors there really isn't much chance of recurrence. And so how to make sense of that, I'm not certain. When I talk with people who come to our clinic and are worried about fear of cancer recurrence, I often find that their fear is not so much fear, it's more realistic acknowledgement that they may have a recurrence risk. And the problem really is how to manage that for them. And so I often find myself saying, let's move away. I know fear of cancer recurrence, I know that's why they sent me late, but let's talk about your worry that you might recur. What did the doctor tell you? What are you supposed to do? How are we going to help you manage whatever this is that how are we going to manage this situation without labeling it? Because I'm not always sure that label is super helpful for people. Again, in terms of addressing anxiety, unfortunately, it is often undertreated, which is too bad because there are many, many helpful resources for anxiety. Anxiety is extremely treatable. Even moderate and severe, situations of anxiety are often, people will get much better with treatment. So it's too bad if people aren't getting it. Sometimes people have this sort of cost of cure idea. It's like, well, I went through this, and so now I'm just going to be anxious, for a while. Everyone needs to decide what they want to manage and how they want to manage it. But I think this is something that's very treatable. So I often encourage people and say, well, you don't necessarily have to have that anxiety. You could try something and see if it works, and you may feel better. It doesn't have to be sort of a fixed issue. So I think, there we go, sorry about that. So I really go back to this pyramid when I'm sitting with patients or when I'm talking with trainees, and what are we going to do with people? So some people come in with anxiety and it's very severe. They're at the top of that pyramid. That's a pretty clear situation. It's unfortunate, it's very difficult. They're not managing, they can't get out of the house, they can't do their chores, whatever it is, but their subjective distress is high. Their impairment is high. We know we have to get them to professional resources. We know that they may need to see a psychiatrist, a psychologist, they may need groups, they may need to go to hospitalization or intensive treatment. It's difficult to manage that, to find those resources for the right person at the right time. But in terms of the decision of what we're going to do, it's pretty clear in these circumstances what needs to be done. Knowing that there are other people who have anxiety, knowing that there are other people who are not past it, and able to be productive is super helpful, which is why I put that resource there. Skipping down to the bottom side of the pyramid, there's the people who are pretty fine. They're like the rest of us. Those people are it's more straightforward as well. So we know they're going to need routine and supportive care and guidance. They're at higher risk than average people. If they're feeling that fine now, there may be challenges down the road we want to keep them informed about. We want to educate them about what might be coming from their medical providers. We want to connect them to cancer support groups and agencies that might be able to help them now or in the future. We want to identify any goals, that they have, any challenges, and give them some monitoring. Say to them, well, it seems like things are going well now, or your energy isn't great, it's getting better. So we don't necessarily think you need to jump into a fatigue treatment program now, but let us know in 3 months. If it doesn't continue to get better, we may have this conversation again. So that's sort of anticipatory guidance. Then there's the people in the middle. And these are the people I think, in my experience, are the most complex. They're not so, symptomatic or so distressed that I feel like I need to, get them into urgent psychiatric care, but they're not fine either. They're in the middle. So I definitely suggest for them this routine care that I mentioned before for the people in the blue, the connecting them to resources and anticipatory guidance. But I also think they need more targeted care. And that usually requires some evaluation from me, from them, from some other provider, or the patient independently to figure out, well, what is the issue? How much is it? What is it interfering with? Where do I want to go? How would I like to manage this? What do I think might be useful? Some of it is doing some real problem solving with people. People may have a problem like fatigue, or they may have a problem like transportation, or they may have a problem like, the neighbor that brings home a casserole every day and they really wish they wouldn't. And to be able to get past some of the avoidance, say, okay, well, you've tried now for a while, and now you maybe need to really deal with some of these problems that you were hoping would resolve in the first few months of survivorship, but they haven't. How are we going to put them on the front burner and deal with them? Other issues like stress reduction, because that can be very helpful for people with anxiety, and then maybe more symptom-focused care, not necessarily urgent mental health care, but mental health care directed at those symptoms. So there's lots of different kinds of stress reduction people can do. These activities are going to be different for different people. Some things you might be adding in to your repertoire. There also may be things you need to cut out because they're causing stress that you need to rethink. There are many, many anxiety and stress reduction resources that can be helpful for people. A worry journal I recommend to a lot of patients as a way to set aside time for them to have their worries and contain their worries, and also maybe have the worry be a little bit more productive. Think about what they could do or what they could just let go and accept. In terms of, I'm going to skip a little bit here. So I also recommend some cognitive behavioral therapy for people who have anxiety. This may be something they do with a professional. It may be something that they do independently with a group or in self-help. Really trying to get them to question the thoughts and reactions that they had that may be self-defeating, really questioning some of those thoughts or shifting them. Some of it is talking back to those thoughts. I'll show you the slide with Mary when we did this. She doesn't want to go out because her friends invited her and she might be fatigued. It's sort of like, well, how do you just sit with that thought and you say, well, yeah, I might be, but I want to try. If I don't try, I'll be home alone, and that's no good either. Having a conversation with those thoughts can be helpful. And that is, in fact, a lot of what we did in the group with Mary. And a lot of it with other people saying, well, what would your friends say? Well, if your friends were here and they heard you say this, and Mary starts to laugh, she said, oh yeah, they would kick me behind. They would say, just get out here and do it. It's like, okay, well, how do we get those voices into your head and not just this, what happens if I'm too tired voice? A big part of this is also talking to ourselves like we're our own coach. We're much nicer to other people when we help them with their problems than we are with ourselves. And so, which is why groups are great, because we're all so helpful to each other and we're so not helpful to ourselves. So generating alternatives, being compassionate, this is all easier when you're talking to someone else. So, this was really helpful for Jackrabbit Bob. Jackrabbit came from he was the only gentleman. The women in the group started calling him Jackrabbit Bob because he wanted to do everything fast. And it was getting him into trouble. And, so part of it was saying to me, what would you do to a friend? Have you had a friend who had an injury? Yeah, my friend had a tennis elbow. Did you tell him, let's go play tennis tomorrow? No. Well, what did you tell him? And so he was really able to his compassionate, thoughtful, mindful rehabilitation mode, thinking it was for someone else, and then sort of move that onto the focus for himself. It's also important to tell people, to get past some of these thoughts, is you can have thoughts and not believe them, right? You can say, yeah, I have that thought. It's not really rational, but I have it. You can Another way that we say to people is you can pick an action that goes against your thoughts. So there's a lot of celebrities who have very serious stage fright. So this is Jack Nicholson getting his Academy Award. He says, sometimes I think I worry too much, I panic, I should dare to before I start, and I say to myself, what is it that I do again? He says, my mind is totally empty. He panics. So you could be Jack Nicholson and say, I'm going to stay home until those thoughts go away. I'll see you later. When the thoughts are later, I'll come back. Or you can say, yeah, I'm totally panicking and I'm going to work. It's not in a way of saying, suffer in silence, but a sense of saying those thoughts are not going to get in the way of my goals. And so that was really helpful for Mary to say, when you go to see your friends, whenever it is, you're going to be worried, you're fatigued, and that's okay. You can still go. And sometimes these examples are very helpful for small groups. We all think everyone has it all organized. I don't know if you can see the slide. All these people really seem to have it together, and I have no idea what's going on. And that's a big part of the problem, especially when you see someone, Jack Nicholson, getting his Academy Award. You never imagine that he has anxiety. But he does. I think a lot of times people will say to me, what's wrong with me? I'm sad, I'm suffering, what's wrong with me? And often we talk about, well, is something wrong with you, or are you just suffering because things have happened that have caused this suffering? Maybe it's part of the mending process and something that can be managed and accepted. We definitely, in our culture, have trouble expressing and seeing negative thoughts and feelings. This doesn't help any of us. It particularly doesn't help our survivors at times who feel like they're supposed to be happy, everything's good, treatment is over. And the parenthesis is, so what's wrong with you if you're not feeling that way? So it's important, I think, to be on the lookout for that. I think it's important to accept feelings and understand that, get out of the happiness trap, so to speak, that we all have to be happy all the time, and to be sort of flexible with feelings. At times, really deeply feeling them, mourning our losses, thinking about difficult things, and other times putting them aside and doing the things that we want to do in our lives, trying to reach our goals. It's important, I've been talking about the challenges. It's important to acknowledge that people also experience some growth and meaning many times in the course of their treatment. It's not a but situation, it's definitely an and situation. People say that they have, clarified values, that sense of meaning has deepened, relationships have deepened. This quote from this woman saying, after treatment for breast cancer, I knew my life had changed forever. Nothing could ever be the same. I was very sad at my losses, but I felt I had been given the gift of a new life. She means and, but it's something well with So as I get ready to close, I do want to say, it's really important that we celebrate all of these strengths and gains. And certainly in my career, have seen this didn't exist 20 or 30 years ago for people. And so it's great that it's out there. I think at the same time, we also need to make room for the people who say things like, I should be grateful even for this lifestyle and not complain, but it's hard when you have little quality of life. Not to take away from any of the great successes, but just to remind us we need to make room for a large range of feelings across survivors and also within individual survivors as well. I'm going to stop there just by saying to remember for all of us, if we feel like we don't understand and things aren't making sense and the pieces are not falling together, it may not be us. It may be important to recognize that it's complicated. Survivorship landscape is very complicated, as this group knows, across regions, across people, but also within individuals as well. So I'm going to stop there.